self-report to the symptom management team over the phone. So we're recommending for these first 2 entry points that it is to stay in current state. So still being introduced at the first initial visit, and then patients continue to self-report to the symptom nurse over the phone. It was identified a third way that patients can enter the symptom management team's radar. It's not super common, but it's still a way that patients are entering. And that is when providers or nursing are writing in the patient's physical chart for this team to look or call the patient. I quickly discussed this with you, Karen, the option of going through with Message Center. So just a little summary of that. The team would create a refer to LGH patient symptom management team order viewable to LGH only. I'm not entirely sure of the name of this order yet. We still need to iron that out with RDS. So are you okay if it was to refer to LGH patient symptom management nurse or team? Do either of those make a difference for you?
Sorry, I'm having a hard time hearing. We've got echo in the background here. And yeah.
Okay, maybe if one of you guys goes on mute, that will help. That might help with the echoing. Lee, do you have a question?
Yeah, can you go back to the previous slide?
Oh, sure.
Oh, both of us did.
So these 2 things are extremely different. So we also do referrals to the palliative team, which is not symptom management. So
this is just symptom management team, not palliative.
Yeah, but in the Squamish it says in that one is from palliative, but we do referrals to palliative too. But those and we usually do that on paper. That is not symptom management, and so what you have comparative here, those are very, very different things.
Yeah. So we were originally going to have the Squamish team join us for this session, but this is very LGH focused. So we're going to
ignore that.
Yeah, we're going to include them separately over email. We reached out to Tash about that. So apologies, this is a bit confusing. We're just focusing on LGH content and the patient symptom management team only.
And then the part 2 of that is we also should have a way of referring to the palliative team because we currently do that through paper.
Yeah. I just want to defer that to Haley. Is that something that we want to discuss with our palliative team CISs?
Yeah, I mean, so it's a whole separate team / clinic go live for them. They're not part of the oncology clinic go live or chemo clinic go live. So it'll have to remain in future state for now on paper. Okay. And I'm sure our colleagues at some point will be revisiting their workflows and seeing what they can get on live if they can. But for now, that's where the scope of this implementation stops. We're not taking other clinics also live with non-paper processes. Not to say it won't come.
Okay, thanks.
Thanks, Lee. Okay. So back to the third way that a patient can enter the space is either by the oncology provider or an oncology nurse writing in the patient's chart for the symptom management team to enter for the symptom management team to take a peek or call the patient. So as discussed in the previous session with Karen, we discussed option 1 to create a referral to LGH patient symptom management team order to be viewable to LGH. So I just want to clarify or double check that this order, if it said nurse or team or clinician, if that makes a difference for you guys. I'm just not sure what RDS, if they have specific order wording or details that they have to have.
I wonder if it should be oncology in there somewhere, because LGH means to me seems like it's the entire hospital, but for us that's particular to our clinic.
Yeah, that's a great call out. I can definitely try and incorporate oncology or chemo clinic, something to identify the symptom management team.
Oh, yeah.
We might run out of characters, which might have been why it wasn't recommended.
Right.
So with that, we're looking at the order, right? So refer to LGH oncology, patient symptom. Oh gosh, yeah, we're gonna definitely run out of characters.
Right.
I know
Would an
some,
acronym work? Do you guys ever go PSM team?
We usually goes SMRN for symptom management nurse. Can we do? I don't like it because some people may make it, mistake, but make you put symptom management SM. I don't know.
Let
Do
me
you think it would be okay to
yeah.
say refer to LGH chemo patient symptom management and drop the team? Because I mean, that's one extra character than what it is right now.
Or on ONC.
Yeah,
Yeah.
given that.
let me play with the character limit and throw some options and we'll come back to it, I think. Let me just
Yeah.
put, that's a good point. We should have oncology in there.
Mhm.
It's 40 characters, so I have to count, I'm gonna count them.
Okay, thanks, Haley.
Okay.
Additional question to that, do we want this order viewable only to LGH or would we want it viewable to other sites? Do you ever have instances where another site would be entering these orders?
We usually do enter it just for us, not for
Mhm.
other hospitals or centers.
Okay, so keeping it to LGH only.
Yeah.
Okay. Um,
I think in the case like of a Squamish patient or something, or they might just would probably call, or they'd either deal with it their own way or they would call if they really needed our support.
Haley?
Just there's two, the way that LGH clinic is built is that it's got its own, it sounds off from a build perspective, it's in its own facility. So we will obviously make it visible within the clinic because that's where most of the patients will have this order placed. But we'll also make it visible within the inpatient and general hospital facility space. Is that required, or did you guys want us to try to keep it tighter? Yeah, inpatients. Good. Just making sure.
Okay.
Thanks.
Thanks, Haley. Okay. And then going with that order would fall into a LGH patient symptom management clinician pool. Again, we can look to see if we can get oncology into that title as well, but again, character limit. We can discuss some options and then send it your way, and you can let us know which works best. Okay. Okay, so regarding scheduling, so what current practice? So patients receiving treatment are scheduled into clinic appointments by the clerical team. Patients requiring symptom management only visits are booked directly with the symptom management team via the phone, and they're not entered into the scheduling system. So what we need to know is what is the patient volume of scheduled appointments? What's the volume of triage calls, patient walk-ins for the symptom management team? Do you have an estimate?
Yeah, and on before and after long weekend may go above 20 calls at least
A day?
a day, yeah,
Okay.
and sometimes 20 of the emails as well. But usually it's not less than 12 or 14 per day.
How about patients coming in as a walk-in?
Some days 2 or 3 at least.
Okay. And then
And sometimes I ask them to come.
2 or 3. Okay. It's good to know the volume for if we're going to have clerical like be in charge of the of scheduling piece. Good to know how many patients they would need to schedule in versus if this was owned by the symptom management team. So our third point is there an interest to move the symptom management team scheduling into Cerner? Lee?
It's pretty, so we do have lots of walk-ins, as Zara said, and once in a while, the doctors will say, can we schedule this person in for fluids or schedule this person in for something? So we do schedule the odd one, but just the nature of the business is people don't know when they're going to be needed or need us.
Yeah.
So you just kind of have to you just have to roll with it. Like, you talk to somebody and they've had diarrhea all weekend and nothing's working, or they've been vomiting or whatever, or they're struggling. And then you just like, okay, you know what, I really think you need to come in, but it's not something that we can prepare ahead of time.
Can predict.
Yes, totally. The scheduling piece for triage would help capture the amount of patients that you guys are taking in as a way of like tracking It wouldn't be scheduling an appointment for a triage. It would schedule when the patient arrives, if that makes sense.
So
Do
usually if
we
we
have-
know someone's
Sorry,
coming,
go
we'll
ahead.
just tell, the scheduler, the front desk will say, oh, Mr. Smith is coming in. They'll be here at 10. Can you add them in? And so we do that already.
So is there an interest, so that is getting scheduled into system or
What-
They add to the tracking shell.
add to the tracking shell? So is there an interest to add this into scheduling? Is,
That's, if they're on the tracking shell, they probably were scheduled and then checked in.
okay.
Yeah. Just-
Um,
That's how
We're-
it would show up.
that makes sense. Regarding organizing your day and patients that you need to call and keep track of, is there an interest in scheduling that?
We usually track, like they have a tracking board. We write all the patients and the contact number and why we have to call, so we know what we are expecting from point of us.
Mm-hmm.
I don't know. We can add it to the Cerner too, but I don't know how realistic will be at the end.
Okay.
Someone has to enter all information every day for the next day, so.
Okay. On my next slide here, I just have an option of what the pros and cons of if we moved the symptom management scheduling into Cerner, build considerations. Oh, Lee?
I was just wondering if you had an example of how that would look, and is that what this is?
Yeah, this is kind of diving into if we went to moving it into Cerner.
Okay.
So the workflow would be appointments and appointment management would be scheduled into Chatbook. Some build considerations, we'd have to consider resources, who would we book this to, and the appointment types. A call out here, we'd probably want to distinguish between scheduled appointments versus triage, just for tracking purposes. So some pros of moving this into Cerner would be tracking from an operational, clinical, and data analytics standpoint, visibility for patients in the patient portal when the patient portal goes live. That also depends on the appointment type. So they'd be able to see their appointment, and then visibility across the team. Some cons is an increased workload for the team that would own scheduling. So whether that's clerical versus patient management team, and noting that if the patient's symptom management team owned this, they would need some additional training for scheduling.
Would this be tied into like the referral process? Like if we were referring to symptom management team, could they take that referral and like, I would like to see an example of how this is used, like, I don't think the IV team or other teams that get that kind of referral and how they deal with it.
So it would, that order that was placed would fall into the message center pool. And so the symptom management team would then view in their inbox of the message center, and then that's how they would know to contact that patient and then to schedule that patient into system, or to let the clerks know to schedule that patient.
So what is it from the referral process? Can you schedule it easier? Like, does it talk to each other?
So do you mean like the order would then create a scheduling type order?
Not really create it, but you could just kind of click on it to add it quickly to. Yeah, would it be connected? Like, can you connect it somehow?
Sorry, I'm not understanding connect it to
I
where.
don't know. Like, so say you get the referral and it's in messaging center and it's can you like click on it or add it, move it into like a scheduling? Like, is it something that can be?
Mm,
It won't
So-
move from message center, but you can, you'd have say message power chart message center on one screen, and on the other you go into Chatbook and ad hoc an appointment, and that's if you felt like that you wanted to schedule the patient. That's how that would work, I think.
Because I love the idea of the data, because our symptom management team is extremely busy. And I love the idea of the data, but I just, if you get a referral, do you get just a referral once, or is it every time? I don't know.
It would be
other-
a one-time
Yeah.
when the order's placed.
Okay.
But with that, you can always schedule like your initial assessment, and then if you think follow-up's needed, you can drop a follow-up for next week. Like you'd like to talk to the patient again next week. So you can kind of make it as recurring as you want by scheduling it. So that's why we thought it was helpful to track patients. Especially like if you felt like you need to call them again next week or a couple days. That's good for tracking. Does that sound like it could work for you guys?
Sounds like a lot of work.
And extra step. So we have to, you know, double doing.
But it
I
would be
agree.
nice.
I like the idea of the data, and I like the concept of it, but it's the workload. Like I know even just like watching the clerks do a check-in, it's like 17 check-ins, like clicks. So it's not very, time efficient. So does our symptom management nurse then like just keep track of who is here for the day and go tell them, can you check these in after the fact? Or
Yes, you can do that too.
like,
You can check in after the fact.
or is it easier just for our symptom management nurse to learn it and just do it themselves instead of having to write it down and go tell the clerks? Or like, I don't
Yeah,
know.
I have
I like the
this-
data piece. I'm not loving the whole thing though.
So-
sorry, I have like a pros and cons.
Yeah, because if you were already writing it on a paper list and the chat book kind of allowed you to make an electronic list, you're already writing it. And so say it's a different symptom management nurse tomorrow, can they look at that chat book and see what happened? Like see who had called in?
Mm. Sorry, you mean like
So sorry, I got distracted, so I didn't hear the full question. Lee, that's my fault. I let myself look at a ping. That was a bad idea. Can you repeat the question for me?
I'm just wondering, the symptom management nurses are already writing kind of what happened today that needs follow-up. They're writing it on a piece of paper so that the next nurse, if it's a different nurse tomorrow, can know what to follow up on.
mhm.
So when you enter all this stuff into Chatbook, can you look back from yesterday and see, like, I would love to see an example of this.
You can
right?
access the documentation. So documentation that should be documented on the patient's chart.
In the
assessment.
patient's chart, but how do you know to look in that chart unless you have a piece of paper with a list
Right.
or a schedule with a list?
Yeah, the follow-up for the next day. I don't like it's sounding like scheduling just for tracking like everyday things that happened. I'm trying to think of how that would work.
Because if
We could
I
probably
come
take
in
that away.
today and a patient was really having a bad time yesterday and Zara was with them yesterday and she wrote in the patient's chart, but she's left me a little piece of paper that says, Lee, can you please call Mr. Smith today because he was having a bad time yesterday?
Yeah.
And if that was in like some kind of calendar on, like, I don't know, I can't envision how to use this because I don't know what it looks like. And I don't know if there's an example of something that you're already using that we could see. But if like, I want to have like a little symptom management kind of like referral list so that I can look back. Yeah.
I think there's ways to do that in Message Center and not scheduling. It's just that Message Center is not the data tracking.
Right.
I feel like there might be a better way to back into this one. But yeah, don't mean to go back to the drawing board, but I think we could, understanding that you guys would like to take tracking and how you guys track, that changes maybe what we could do. I think what we might recommend. So, sorry, Zara, I don't mean to speak over you. Go ahead.
So you okay now? My question is sometimes doctors sending an email, please check this patient, please do blood work for another patient. So this is in our tracking. How can I transfer them to Cerner? And still I have to write on a paper and pass it to tomorrow nurse, make sure they following up.
Yeah,
So-
we're trying to remove that paper. That's what we're trying to remove, so that if you and Lee won, or whoever's covering on the lottery, we don't, it's not a piece of paper that's somewhere out in the ether, and it's in system. It's part of we're using the documentation to guide what we do.
So
the
do
next
we
day.
have access to the yesterday symptom management call list?
Yes, if it was scheduled, yes. That's why we were going with the
Okay.
scheduling, like you can see yesterday's, but it doesn't mean that like everyone yesterday requires follow-up from lead or whoever's going to cover you to that next day. Alex, do you agree that maybe there's like, we could take this back a little bit to the drawing board and
I
see?
think so, yeah.
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 Appointments aren't the only way to track in system. There's note types, there's power forms, there's things. It's just a matter of finding something and creating it. Yeah, so appointments are the quickest way and the easiest build. So that's why we start there, but it sounds like we could maybe look at it and we'll just come up with another option.
Mm-hmm.
Yep.
Yeah.
Good. Good discussion. Do you have a copy of the paper that you guys pass forward? And is that something you can scan and send to us? Just so we have an idea of what information you're passing on?
I have this one. I don't know you can see or no. We
Oh,
write the
I have
patients.
a copy of that.
You have, yeah.
Yeah.
Okay, great.
The date and everything.
Okay. Yeah, we'll look into how it can be better tracked for you guys, and then we'll hopefully come up with some more options that works better.
I think that, and you know what, this is kind of lending to just a thought that as we go forward, we might not be able to get the best solution for this go live. It might be something that we do in sustainment, because then we can focus more to a more like team specific build. And even this, I can see benefit in bringing Richmond in, because they also have like gaps in their patient symptom management workflow. And then that way you guys are standardized as much as you can be, maybe not. So with that, if it's not scheduling and we think that we might go another route, like tasking, there's other things that we can do and we know about those. We can't likely get those done for this go live. It might be something that we go live with the paper and we create this in the future. Once we go live, everyone's stable on oncology order entry, and then we revisit, okay, how do we get your documentation, your tracking, everything in system so that it works smoothly, but it's all in system. Does that sound okay?
Yeah, and I think that, like if some things that are a lot of clicks, like when we first started Cerner, you're like, oh my gosh, just putting an IV, I have to do like 17 clicks, and then you just do it really quickly and it goes fast. And so some of these things that we're like not sure how much work will that be, and what do we have to do to make that happen? Like, we will get used to it, but yeah, we just want to try to find the best way so that you can to adapt to it. And
Absolutely. I think you're right. Like Karen, as you said, you look at the clerks checking in and it looks like 17 steps. I can guarantee you it's like, you go through it and you don't even know what you did, but it's like riding a bike and it's done. But you're right. When you're learning it, you're forced to do all these little clicks and it seems arduous. So completely understand. Yeah, I think it's feeling like we can come up with a more fulsome and meet all the requirements and not create kind of these arduous workflows if we maybe pause on this like build for what we can pause on and push to sustainment, because our team's not going anywhere, and this might be good to even bring in Richmond and design it in a more fulsome way. Yeah, it's good to know. Thank you guys. It's good chats.
And Richmond has that really cool app, don't they, where they
Symptom MD or Patient MD or something. Yeah, it's a very cool app, but it doesn't, they're still having to document insert. The app works for getting virtual assessments from the patients, and then they can time them, but it's still very manual. It doesn't speak with Cerner, and they still have to do documentation and everything. So I wonder if it all could be made better for them. Yeah. Okay, good.
Awesome. Great discussion. Okay, we'll just touch on documentation now and what that can look like in system. So iView has their own pain management section that you can document in, the ONC-HEME BMT assessment band, and the adult system assessment band. In documentation, there are oncology pain and symptom communication notes. There's a consult note and a follow-up clinic note where you can use to document symptom management specific note types, and it can be viewed by other members of the team. There's also the team communication section in iView. Are you guys familiar with that section? Okay, that is another, and it's used at the clinic.
Yeah.
No, it's not used very often. Lee's shaking her head. So it is a great tool to use to communicate, but it is a tool that everyone needs to be on board with, or else one person enters something, no one else reads it, kind of thing. Lee, what were you going to say?
Yeah, I was, where are we here? Sorry. Because I think we use it like if we have inpatients and we want to leave a note for them, we use it for them. And we know we're really fond of sticky notes in this clinic, and we have paper to put them on. And so to me, when I'm out there kind of getting us all going on this as a when we start go live, I'll say, and there's your sticky note. Like that to me, that team communication will be our sticky note.
Mm-hmm.
And I will encourage nurses to, when you're first logging into a patient's chart, you will look at, the orders and the documentation from the doctors, and don't forget to look at the team communication because that'll be our sticky notes.
Mm-hmm. Yeah, and that's a good way too. I don't know if it will solve it, but for nursing, if a nurse wants the symptom management team to look at the patient, they could use that area too.
Yeah.
There's also power forms, so adult pain symptom management in the palliative care power form, and then advanced care planning in PAL benefits is another power form that can be used. Any other type of documentation that you are using for your patients that you don't see could be used at any of these sections? Like regarding symptom management?
No, we usually chart in these two parts,
Or free.
or free documentation.
Mm-hmm. If doing documentation, it's probably best to use a specific note type just so that other teams know, oh, this is from the symptom management team.
I consider all those notes, these to me look more like something that the palliative team would be using than us. The way
Okay.
these are written, they look like a palliative doc note, but I don't know what Zara uses, but I would do like a nurse narrative, and then I would just title it whatever the, constipation or symptom management or something. But these to me look to me very much like a palliative team notes.
I've done both.
Yeah.
Sometimes we use the telephone triage one.
That's a good one too. Yeah.
Yeah.
Okay.
Something that's missing from the iView here, I mean, it's within the on-came BMT assessment, but Lee, when you said constipation, I was like, oh, that's pings me to that. Do you guys use the CTCAE to document? Yeah, you will use that? Okay.
All the time, yeah. For every
Okay, great.
treatment. And then if something is outstanding, like if they have just constipation and it's normal, but if say they were phoning symptom management and then you had to write a note because you did more than that, then I would use a note.
I see. The note is the elaboration on it.
Yeah, like if it's basic and managed and it's like a problem, but it's a grade 1 or 1 problem, then you don't need to write a note. But if you're getting a phone call about it and you're dealing with more of it, then you probably need to write a note.
So what we found at Cawthon, I think we showed before, is that the elaboration that we're putting in the documentation section could go in a comment on like the grading.
Oh, all the time we do that. But so if
Okay,
I'm
okay.
saying a patient comes in, oh, I had a bit of constipation and I'm just reviewing with them I'll say review protocol, patient taking Restoralax. No big deal. But a patient's like, I haven't had, I've been, I know, extreme stuff, right? Like it's like grade 2 or 3. You need more than just a quick comment in that. You need to, like if the doctor hasn't addressed it, it's like a day 8 and the doctor hasn't seen the patient. And I want to make sure that it's an extreme, it's a grade 2 or higher, I would recommend writing a note.
Okay, so you find the comment part maybe like is limiting for how much you want to, like, yeah, it's limited characters.
So that's not really my issue with it. It's my issue is if it's a manageable thing, but if it's something new, different, undocumented by the doctor, I think it needs to be in documentation, because also I have tried to show our doctors how to look under oncology to look at our assessment and but I don't know if they do.
Okay, so it's provider
But
visibility.
then that's double charting, and why are we doing that?
Yeah.
But only if it's grade 2 or
I-
higher, Karen. So if the doctor said patient was very constipated, patient had a lot of pain, I'll just write it as a grade 2 and I won't write a note because it's already being dealt with. But if it's not being dealt with and it's an in between, I won't use, if they're scheduled for an appointment today, I 99.9% time use only the CTCAE. But if it's a triage or somebody coming in extra, or it's an event that's
Okay,
not
Yeah.
in there, then I'm not going to use the CTCAE, whatever
Okay,
it's
yeah.
called.
Yeah, that's true. Yeah. Then if patient goes to emerge, someone can see the documentation.
Yeah.
Yep, that's a good point.
Yeah, good points. Another call out here for documentation and using these specific document types is you can pull reports from it. So that's another way of tracking, not necessarily triage walk-ins and stuff and the, like what type of symptom management is being treated, but it is a way to track how many symptom management patients in a way.
I
You
always put the symptom management, for example, nausea, back pain, or whatever patient's complaint is.
Okay. Okay. Just some helpful tools that we can visit too in sustainment too, but there are auto texts if the team is interested in for their documentation purposes. Are you guys familiar with auto texts? So it's a little like shortcut you can do on your computer, and it will pull phrases or sections or assessment pieces. Then you can fill out. It's like a shortcut type tool, and we can create that, and a certain nurse could own that, and then share the shortcut with other members of the team so they have all access to it, and it can be managed by the symptom management team. They can update it as they want, if that's something that the symptom management team is
Yeah, I
interested.
like it. Yeah.
Okay, we can visit that, and we can help guide you on how those can be created. And then there's also dynamic work list, which is another area in PowerChart. Are you guys familiar with this one? I can try and pull it up on my end just to show you, because it's kind of hard to explain without a visual. Just sorry, give me a second. My dynamic work list.
We learned it little by little where to find the information, but I like to know if there is any shortcut.
Oh, yeah. Yeah. So for dynamic work list is you can create your own patient lists and filter it out. So this one, I just have an example for research. So these are all the patients in build that are research patients, but you can create your own list. So these are just ones in build. These are all just build patients. You can add patients to the list. You can modify the list. So you can kind of, this is a way also of keeping track of all the symptom management patients you are seeing. This isn't a very good example because I don't have it populated for patient symptom management, but you can filter out by the appointment status, encounter type, and things like that.
So if you had this list, so Zara had this list, and then I wanted to, I can't see her list, right?
Yeah.
You
No, you
can
can.
you can access other
Yeah.
people's lists.
Oh,
Oh,
because that would be a nice way of
yeah.
adding, like for those, like
Follow.
instead of the paper list, if you had this
Mhm.
list.
Could do.
Okay.
Question for you, Alex, because I can't remember. Is there like a comment section or column? I don't think there's any free text or anything, but I guess you
I-
put it in team communication.
Yeah, generate communication. What does this do? This creates a note type. So, but I guess that's not
So
really a
it's
face up.
document. Yeah,
Yeah, it's not a
it's
face up
document.
like thing. Um,
Just thinking for you, for Lee and Zara, you guys mentioned that you have like, you leave your blurbs for each other, like, hey, I talked to him, you can see my documentation, but ultimately I think that maybe he should do this, this and that, or whatever it may be. Just want to make sure you have a space for that casual post-it or blurb. So we just might have to look at the list, see if there's something that we can do there or have something show up, if, because it is easy to maintain this list. It pulls on the whole location. But then you can have a list that you just put like your ranking of a patient. So we can show you how to use it.
mhm.
And it's not something that we'll have to build for you guys. So if it is like we come closer to go live and we want to look at using it, then we can meet with you and see if we can set up a list and see if you, once you see clicking through it, if it feels right to use it, maybe you'll move to it.
And sorry, where does it live?
So it lives right here in dynamic work
Ah,
list.
got it. Okay, thanks.
In fact,
Yeah.
we can send you some help topics. I know you don't have a ton of time on your hands, but if you wanted, we can send you how to click through it. And so you already have access to it. So it won't change, but if we can help you tailor it more to your workflow, we will.
Yeah, we can play with it.
Yeah.
Okay.
I'll send you up with a help topic in the chat.
Great. Thanks, Haley. Okay, so those are some helpful tools. And then for forms, we didn't have any additional forms from LGH, and I just wanted to double check that there's no symptom management forms.
No.
No. Okay. Okay. So that is all that we have today for symptom management team, but we'll definitely take away and revisit tracking, scheduling pieces that hopefully work best for you guys. If the dynamic work list is something that you guys seem would work, that would be great. Any questions from you guys?
No, nothing for now.
No.
We do have time. Did you guys want to see what the scheduling looks like? And Alex, are you able to
So I have
show?
just, yeah.
Even take your time. Is that of interest, or would you guys rather the time back? It's totally up to you if you want to take this time. We know we're taking a lot of time of your guys this week, especially.
And then we have another meeting on Friday, correct? 8.
Tomorrow.
Yeah.
Yeah. Digging into all the weeds that we still haven't found our way out of in a clear way. It'll be mostly LGH content for tomorrow. So I think it'll be good discussion.
Sorry, my chat book closed, but I can open it up here. So this is the scheduling appointment book. Why are you not getting bigger? Sorry, my build's being a little annoying today. Okay, so I can select, I'm just going to use a BC Cancer because they have a pain and symptom management book already. So I will go to the appointment and I'm just going to use a test patient. So I just have a coastal. Okay.
So you guys, this is new for maybe some of you. So she's found the patient, she's found the appropriate counter. For today, we're using maybe BC Cancer, but or even coastal. Yeah, and now she's gonna define the appointment location, which you can start by you get faster at it because you can put BC Cancer space P and it goes straight to the location. I know she's scrolling right now, but you get faster. It's okay.
I'm still slow with this because I'm not a clerk. So appointment type. So this is the appointment types that they have built out for their symptom management team. So they have symptom management follow-up, a new visit, phone call. So I'll just put new. And the reason for visit, I'm just gonna put constipation. And you have to fill out all of the required fields. So I just have to fill out a provider. I'm just going into a test patient, right, or a test doctor. And then date, we'll just say today. Priority, let's say within the next 2 days. Selecting if an interpreter is required, so nope. And visit, this is an in-person clinic visit. And just making sure no other required fields are filled out. And then I'm going to move this over into the work in progress, called WIP for short, and I'm going to schedule this patient. So, sorry. Normally this has resources built out.
Yeah, just click on the resource one. So usually when you pull it into the WIP, it goes, okay, here are the resources that are built out for that. And it shows you your time slots.
This one.
You can drag and drop it anywhere though for
yeah.
all intents and purposes. You have to drag the resource, yeah.
Sorry. So I'm going to put this for, we'll say 8 o'clock. And here at the time is 8 o'clock. The duration is automatically defaulted to an hour, but you can schedule your appointment or have a set default for your appointment types. And here is the patient for 8 o'clock. It looks good, so I'm going to confirm. I'm just going to pull this screen over. So I have my patient's information, any preparations, the time, and select OK. And it's blue, so that means that it is booked. If I wanted to check this patient, or actually, no, I think that would stay with clerical, right? Or
I'd say so. I mean, it's up to them.
Yeah.
Checking in is easy enough, but especially with virtual and like check-in's it goes pretty fast. You can check in if you want.
mm-hmm.
So how does that look? I know it probably looks arduous. How does it look, Zara?
Yeah, I'm not sure it's practical because sometimes we don't have time to call a patient at that time. I may have to help outside, or I may have a meeting with doctors or another emergency calls from the patient. So my priority will go to that one. So I'm not sure this one will work. It's just extra step. I have to schedule all this patient, and I may not go on time and call them or bring them here. Or if patient is so sick, I have to bring early morning. I cannot wait until 12 to be the appointment time.
Yeah. Two things then, and you're both all very good points for you. You're right. It's more process. One is that we can create appointments that are like non-attend, so they won't show for the patient. So you don't have to be married to the time that it was booked. It's just you see that you were supposed to call Mr. Smith at some point today. So yes, it might be for 9, but if you call and check in later, it's not a problem. It's not, the system's not going to force you to do that at night. You don't have to stick to the regimen. And then a second thing is, yeah, as I said, you don't have to call at the exact same time. I think where this might get like a little more arduous for you guys is if you don't end up calling Mr. Smith today, because he didn't really have to hear from me today. I at some point I can call him tomorrow. I think he's going to be fine. Something happens in your day, and as you said, you get busy. It's that you'd have to reschedule him to the next day. And I think that's what might be more work, is moving the patients if you don't get all the calls done in a day. Just a guess. Lee?
So could we, like, usually we have a list of who we have to call. So can we just give that list to the clerks at the end of the day, and then either that night or the next morning, they can add them in after the fact?
It's kind of like I'd rather, oh gosh, sorry, I'm blue circle buffer on that sentence. Let me try again. So it'd be good to not have the clerks have to reschedule them all back, because we don't have to have them be
Not
appointments.
reschedule, just add, like, they're not
yeah, sorry.
scheduled. You just pick up the phone and you talk to somebody randomly, but you write it down, and then we can add them on. By the way, this
Yeah.
guy called me and I dealt with his situation, and so you just have his name and his PH or his MRN, and then the clerk's added on as a phone call visit later.
I think we could find a way to even like bypass the clerks or not have to go to the clerks, and find an easier way for you guys to document in the patient chart, but then also then be able to pull it. Then we don't have to schedule. So whether it's like a power form, or you guys get your own note type, and that just your documentation itself is the documentation of that instance, so that we can pull it later.
Okay,
make
and then you
sense?
could pull those numbers of she did
Yeah.
this many triages, and yeah.
Yeah.
Okay.
I like the idea of a power form better, because you could say this was a triage. Patient was seen today. Like if you click on the things, then we can pull that later. How many patients did you pull in today? Or, like it's easier to pull the data.
That sounds really good.
That sounds
But
better, yeah.
I think we're not in the habit of always filling out like sometimes you just phone and just tell them, yeah, no, that sounds good. So there's a lot of phone calls. It's like, can you just check if my CT was ordered? Can you just check if can you help me with my blood work? Like,
Yeah.
really random.
My blood work.
Yeah.
And that's not worth sending to the clerk to schedule, but that did take up time for you to give them that update.
Right.
So whether that maybe that's what you get as a power form, and like that is your main work form. You're like, this patient, I pull it up from this patient and I say called for results.
And normally I would not document that, because I've dealt with it and it's not a issue. But
it's not worth the time you're going to put into document.
But if there
versus-
is a
yeah.
way to document that on a power form really quickly,
Yeah,
then that would be a way of keeping track of the statistics, right?
I like that idea, and I think that we could sell that idea. So, and that's why I think that it would be better to be designed in sustainment. We'll take more time, and we'll see if we can get it done, and then even Richmond can use it. And when we get other sites involved, then we get a higher score on the priority list of building. And yeah, I think that it could be done. All this to say, we're at the end. We've seen scheduling. It sounds like not scheduling for going forward for this team, but we can still pursue the order to task to message center so that it's kind of removed, because we're not going to have those paper orders where doctors can just refer to patient symptom management. So the order would go still to message center. That's something that your pool that you guys can review, and then everything else for tracking and scheduling stays offline until we get to a space where we can iron this out more thoughtfully. Yeah. Okay. Awesome. Thanks, Alex. Sorry, I didn't mean to
No,
take over.
that's
Just want to
okay.
make sure I had trouble. I leave the meeting. I'm like, what did we land on there? So that helps. Thank you guys.
Yeah. I see we have 5 minutes left. I know, Lei, you said something in the beginning. You weren't able to get to the NST form. Did you want me to show you? Sure. Okay. Okay. So I'm just in a oncology nurse position, and I'm going to ad hoc. Here, I'm going to go to assessments. And then, sorry, give me a second to find it. It's really small. Where's it on key? BMT. It's in one of these. Give me a second, sorry.
It's adult intake history, I believe.
There is a just NST form though.
Yeah, it is.
Yeah. Like
Go to
you're right.
Adult intake history, and then nutritional screening tool.
Oh, we're on a different position. You're on an inpatient position, Alex.
Oh, sorry, guys.
Inpatients don't have the power to do NSTs. That's why.
That's why. I was like, what is
Yeah.
going on with my screen? Sorry, guys. I really don't want to take up more of your time.
Anecdotally, as she takes up more time, whenever I think NST, I think back to my antepartum days when I used to do NSTs for the baby monitoring, and I can't
I
help but
found
get
it,
that out
Alex.
of.
Did you?
found
Okay.
it? Good.
Okay.
And
Okay.
then on that same screen is also the ones that like BC Cancer use, the oncology comprehensive intake and that P-scan, psychological screening, the ones we haven't started yet.
But we're looking to start. Is that, well, should we teach your nurses all about it?
I don't
We
want
probably
more
should.
work.
We should be, if I think BC Cancer is using them, we should be consistent, but
Did you want us to include that as part of nursing training for intake? That's the question, because we can say this is your.
yeah, that's a
no?
good idea.
Okay. Lee's saying no.
Good thing I'm not in charge.
It is a long form. The thing is, so comprehensive intake and nutritional assessment is kind of an easy add-on in the sense they're both very like lengthy. The comprehensive intake, P-scan's even longer. So sometimes what some spaces have just done, the patient does the form and we scan it back in. So we hand it to the patient.
Self-reporting form? Yeah.
The P-scan. Yeah, we just hand them the paper form. Does that seem like
okay.
that would be better?
Yeah, probably. There's like.
Yeah. Again, we can't pull the data, but we understand that obviously there's got to be a limit to what we expect people to click through. BC Cancer resourced nurses as part of their intake appointments to go through the whole form with patients in the power form, but that's obviously not possible.
Yeah.
So we can go forth with the paper form and scanning back in. So we'll teach that. And then we'll teach oncology comprehensive intake as part of the intake also, if that helps. Yeah. Okay. Got a lot ironed out. Thanks, guys.
Yeah. Thanks, Ellie. Okay. Thanks everyone for meeting. Have a good rest of your Thursday, and we'll see you tomorrow for our design with providers. Bye.
Thanks,
Oh,
guys.
I have a question, Alex.
Bye.
Yeah.